Morning, everyone. Today our speaker is Dr. Brian Bonfardin, and he's going to present on mental illness presenting in the severely intellectual, mental illness presenting in severe intellectual disabilities. He's currently a faculty member at ESU. He is he's working currently as a medical director at the Steppen House for adolescent sex offender, and he does disability consultations for Helen Ross McNabb and Frontier Mental Health. He is past president of the Tennessee State Chapter for National Association for the Dually Diagnosed. He has a private practice and specializes in autism and disability. He's done numerous talks on psychopharmacology and is published in the field of autism. Please welcome our speaker.
Thank you. How many of you all here are treating people with developmental disabilities? Got a couple hands. Well, thank you all for coming. This is a very technical field, and what I'm going to talk about today is people with severe intellectual disabilities and kind of what the state of the art is of taking care of them. And it basically boils down to three things. One is the use of behavioral data, and the second thing is kind of how to modify diagnostic criteria to suit people with severe intellectual disabilities. And then the third is the act of using behavioral data in the diagnostic criteria to manage medications. And this is a fairly easy thing to do and make a profound difference in the quality of people's lives. One of the benefits of treating people with developmental disabilities is if you can help them, you're helping the direct care staff. And often these are people that are struggling with severe behavioral problems, and if you can get things right, not only are you helping the person with the disabilities, but the direct care staff, the quality of their life and their day-to-day job substantially improves. So this is what we'll be doing, and I will not read the objectives to you. Let me start out with a story, and I apologize because it's a bit crude, but that's my nature. I just don't know what else to say. I was working at a developmental center, and I came to work one morning, and there was a consult in my door, and it was entitled Excessive Mastication, which I thought was very interesting way to start the day. I thought, well, this should go well. So I went to Morning Report thinking, what exactly is excessive mastication? Anybody want to guess? Is this someone chewing too much? I was caught up in the whole, where this could go. So I went into Morning Report, and during Morning Report, one of the medical doctors had to remove a marker from an individual's rectum. He had taken a magic marker and placed it inside of his rectum, and he had to extricate it. And so the medical doctor, Dr. Mason, is a general surgeon in Greene County, and he retired, and then he went into the developmental center work, and he told me, I'm finally challenged. This is completely overwhelming. He asked me in a polite way, why would someone do this? And I said, I don't know. He said, well, you're the psychiatrist. And I said, well, I think we need to know the color of the marker to be able to interpret why this individual placed it in their private area. And he said, well, I couldn't tell the color of it. Obviously. Did I do something?
You're standing right under a speaker.
And so I said, well, we need to figure out the color of it to be able to interpret it. And it was one of those markers that you could smell it. So purple would smell grape. And I told him, well, you just need to go back and smell, and then we'll be able to. And he did not think this was funny. Then he began to explain for us the second case, which was a young man. Well, he's not a young man. He was in his early 60s, and he was masturbating to the point where he had soft tissue damage to his penis. And they had put him in the infirmary and loaded him up with morphine. I thought this was an interesting case. And so he talked a little bit about it that had been going on for a while. They really weren't sure what was wrong with this guy. And then a little light bulb went off in my head. This was the excessive mastication case. See, the person who wrote the consult would not write the word masturbation. They would only write the word mastication. Welcome to Greene County. I mean, that's... So we gave them a data sheet that had a box for every 15 minutes, and there was direct care staff with them, and we told them to put a check in the box for every time this guy attempted to masturbate. And I went in and took a look at him. His private parts looked like a box turtle. There was so much damage to his private parts. And I started talking to staff that had known this guy and worked there for 30 years, and they said he did it every year. And so we took a look at it, and what we saw was, this is what the behavioral analyst said. So the behavioral analysts, they basically break things down into 4 reasons people do everything: to get attention, to escape, the sensory component, and to decrease pain. That's why we all do everything, according to behavior analysts. Do you all believe this? It's true. Everything we do has 4 basic determinants. Did y'all know this? This is how you're being looked at by advertisers, that you do everything for 4 reasons: to get attention, to escape something, to get something that feels good, or to avoid pain. And then they can get you to buy stuff because they know this about you. So as you can see, does anybody want to guess why this guy is masticating excessively? The behavior analyst came back and said to me, he's crazy. I said, is that your clinical determination? He says, yes, he's just crazy about masturbating. He's doing it for all the reasons. You cannot sell to this guy. You just couldn't. As you can see, it's occurring in all different settings. Makes sense? So it's this random, unmodifiable thing. So I didn't know what else to do, so I called him bipolar. Isn't that what we do in psychiatry? All else fails, just call them bipolar. And so he was on Dilantin for the seizures, and I put him on Depakote, and there's this weird drug-drug interaction. Has anyone ever tried to make that switch before? It's really weird. As you increase the dose of Depakote, the blood levels of the Dilantin are affected. And then it makes this really toxic metabolite. And I didn't know this. However, once I got him off the Dilantin and onto the Depakote, these behavioral episodes and the irritability disappeared. He developed the tremors from the Depakote. Have you all seen this? The people in Greene County call it a tremor. Are you all familiar with tremors? It's different than a tremor. I'm not sure what. So the behavior analyst came back to me and said, well, we think the diagnosis of bipolar disorder is accurate because now he's depressed. And he's lethargic, and he isn't eating, and he's lying around. And so I went and looked at him, and I thought, that's not depression, that's death. This guy looked like he was about to die. And we did some blood studies on him, and I had given him severe pancreatitis with this Depakote phenatoin metabolite. And so we put him in the infirmary, and he almost died from the drug-drug interaction. So we put him on lamotrigine and olanzapine. And I apologize, I did not leave the behavioral data in there. And it completely solved these behavioral problems. Every summer would come by, and he would not have these episodes of the excessive masturbation, the irritability, the yelling, screaming. So do you all think he was bipolar? Because he did not fit the DSM criteria. There wasn't, you couldn't. So what we've done, we started this, I think it was in 2006 and 2007, we published a book called the Diagnostic Manual for Intellectual Disabilities. And we've tried to look at the research to say, how do you change these criteria for individuals with mild intellectual disabilities, and then severe intellectual disabilities. And there's not a lot of research, and the book, I think, made some worthwhile suggestions. So we'll take a look at that. All right, so we'll move right along. Has anyone ever done this? Somebody in the eardrum? And all right. So the concept here is that in the past, people with severe intellectual disabilities yelled and screamed, and they masticated excessively because they were mentally retarded. Oh, that's what he does. Or when I was working at the developmental center, they said, oh, he's just on his cycle. And so the concept is that it's just because they have intellectual disabilities that they bite their arm and hand. It's just because they have intellectual disabilities that they are tapping boxes repetitively and pulling their hair and getting bald spots. And what we've tried to do in the field of disabilities is say, no, these are two distinct things. People bite their hand because they're in distress. And it's often because they are suffering from a distinctive psychiatric syndrome. But it's camouflage, it's difficult to discern, and you have to use technology to kind of pull it out. And so I'll talk to you all about the concept. I used to have psychiatry residents come to Green Valley with me. And one of the young women came one day, and I don't know why she got this idea, but she thought if she dressed provocatively, a mild way, that it would help her deal with people with disabilities. But this did not work well because the guys in the cottage, they were very interested in her. And so part of it was we were doing a clinic, and she was seeing the medications that we're using, how we're using them, and all this behavioral data. But part of it was just fending the guys off. And at the very end of the day, and she had this British accent, and at the very end of the day, she said to me, this is, I don't do very good British accents, so I won't attempt it. She said, this is very rewarding work. It's like veterinarian psychiatry. And I thought, she's never going to get to come back here. It's a lot more difficult than regular psychiatry because you're having to play detective. And the other thing that I find about it is that you have to be a really good medical sleuth. There's so many medical problems in the field of disabilities that you have to work out the medical problems. So all of the problematic behavior that we see in people with disabilities, we think of it as a replacement for words. Those staff will come in and say, he's hitting me again. And my question for them is, what's wrong? What's wrong with him that he's having to strike people? Do you see what I'm saying? Because a lot of times people will just say, well, he's retarded, and retarded people hit each other. And we know what the response to that is, right? Well, non-retarded people hit each other too, all the time. Actually, they get paid good money to do it. You can actually bite people's ear and make some decent property destruction, all of the aggressive behavior. So we look at it as a symptom of an underlying syndrome rather than it just being a... so things have two meanings, correct? Right? And so that's the theme of treating people with developmental disabilities, is that you have to get over the initial meaning and then try to figure out what does it mean when someone is yelling and screaming and masticating excessively. What could that be? And here's the differential that I use. This is basically based on the catchment area studies where they went into the general public and they looked at all the different psychiatric syndromes that were in the general population. And what we saw is that medical problems predominate what causes people's brains not to work well. The next thing is that they're on substances. The third thing is bad nerves. You all know about bad nerves, right? Which is anxiety. And then we have the mood disorders, and then all of the other illnesses fall in place. So that's basically what we do. So the very first thing we do when we look at patients who have behavioral problems is we have to rule out medical problems. And I think that's one of the most rewarding parts of treating this population is it puts a lot of pressure on me to be a good medical doctor. that I have to be able to figure out when patients are physically ill, because they'll yell and scream and hit you when they have otitis, and they'll yell and scream and hit you when they're upset about their roommate, and they'll yell and scream and hit you when they're not getting to go to the workshop and see their preferred staff. And so that's a very difficult thing to figure out. They have the most bizarre medical problems. I've actually diagnosed a woman with beriberi. You know what this is? Yeah, it's thiamine deficiency. You know what she got it from? Depakote. It's the most bizarre, rare, unusual side effects they seem to be prone to. It's interesting. People, the word retarded now is kind of, it's moving into the same category as like shut up and stupid, like almost cuss words, isn't it? Does anybody say retarded anymore? Say again? Is there? What movie is it? A comedy where they played on the word retarded. When you look at the word retardant, this is my response to it. So somebody says, dude, that's retarded. I'm like, let's talk about retardants. So a retardant is something that protects us, correct? It looks like that's the biological function of people with developmental disabilities, is they serve as protectorants. So if the influenza outbreak occurs in our general population, the first people to get it are people with developmental disabilities, and it will devastate them. So they are the most sensitive portion of the kind of the outside of the population. And this is where we can learn about the potential side effects of medication. There is a side effect to a medication. People with disabilities will get it first, and they will get it the most severe. They serve as a protectorant for the general population. And it's an interesting way of thinking about people with developmental disabilities. We do know with the medical problems that the poor tone in the central nervous system increases the risk for anything infecting the head, particularly otitis and dental problems. I had a guy come into my office who was chewing large pieces of cotton, particularly pant legs, towels, and washcloths. And when he came into my office, he was actually chewing on a washcloth. And when I grew up, my father liked to fix hamburgers with gorgonzola cheese on the top. Has anyone ever been through this, where you make the hamburger and then he graduated after the gorgonzola to Limburger. And then a certain odor would waft through the house, and me and my little sister would hide in the closet thinking that we could hide from it. And when this guy was in my office, I smelled that hamburger with the Limburger cheese on the top. So what was going on? Anybody want to guess? He had a massive infection in his head. And that's why he was chewing on the washcloth. I had been doing it for years. I pulled the washcloth out and took a look inside of his head, and it was like a coal mine. So many dental caries. We finally got a dentist to see him, and he had osteomyelitis of his mandible. So anytime anybody would feed him, he would explode, and he would become notoriously aggressive. And see how it plays out? So think about anything. The otitis syndromes, externa, interna, sinusitis is rampant. We live in this part of the country where there's all of these allergens in the air, and then gastrointestinal problems are notorious. And I just get kids and adults scoped repeatedly, H. pylori infections, on and it goes. And we just wear out the gastroenterology. And sooner or later, we'll find it. I don't know if any of you all have ever had stomach problems. Many of you all are a little bit young, but as you get older, your bowels will actually begin to fail you and eat stuff that you can eat now, and you'll wake up in the middle of the night, and aliens will be in your abdomen jumping up and down, and it's not nice. And so you get to go take a Zantac, right? And it's like you're cured, and you can't believe that 150 milligrams of Zantac would actually save you from aliens. But if you're averbal, it just goes on and on and on. I had a guy that was eating wooden blocks in Hot Wheel cars, and he had a gastrointestinal problem. Anybody know what that's effective for? He was eating wooden blocks in Hot Wheel cars. They're all about the same size. He ate a couple Army men. He was having esophageal spasms. And so he would have the spasm, and it's just this ripping, searing mediastinal pain, and then he would eat the block, and it would dilate the esophagus. Once we treated it, you just treat it with nitroglycerin, he never ate another object. So on and on I could go with the stories. So we know that individuals that are on medications, particularly phenothiazines, phenobarbital, Reglan, on and on it goes. I've had severe aggressive behaviors due to oral birth control. In women who have developmental disabilities who've never been sexually active a day in their life, they get placed on oral birth control so they have a menstrual cycle, and then they have all of these problems with the oral birth control. So think about medical. And I would have to say about half of my acute behavioral consultations, it's a medical problem. They have a medical problem, or it's the medication that they're on. Benadryl. Just look at any new medicine that they've put on or that's been taken away or a change. So substance abuse disorders are prominent in the field of severe intellectual disabilities. We often don't think about them that way, but it's always those medical problems and it's always the medication they're placed on. So I have a woman, she doesn't have a corpus callosum, and she has a terrible psychotic disorder. And she has a terrible seizure disorder, and she has malignant hypertension. Every time she gets placed on a hypertensive agent, it causes her to have seizures, and then she becomes blatantly psychotic. You would never think that Hytrin would cause seizures, would you? It's the most bizarre things you'll ever see, but it took us 2 years to figure it out. So how would you treat somebody who has malignant hypertension, but the hypertensive agents cause her seizures to worsen, and then thinks there's little boys living under her bed? I mean, we're kind of stuck, aren't we? Anybody want to guess how you treat hypertension without hypertensive agents? We use benzodiazepines with pretty good success. Kind of got her a little intoxicated, and now she's drunk. Or as her staff member says, grunk. You would change the word, I don't know. Drunk is fine. You got to change it to grunk. Dr. B, she's just a little grunk. Well, okay. So any questions about that? So medications, medical problems. If you look at anxiety disorders, these are the most common things that plague us, plague the general population, and plague patients with developmental disabilities. Social phobia is going to be the most common thing in the general population, and what we see with people who have severe and profound intellectual disabilities. So if I'm fearful of public, and you take me out into the public, you take me into Walmart, and I strike you as a care staff, what's the reaction going to be? If I go to Walmart and hit you, what are you most likely going to do? Any guesses? What's direct care staff going to do to punish a patient that hits them? Take them back home. So then it becomes this reinforcement that every time I go into public and I get anxious and nervous, I hit the staff, they take them back home. Make sense? So it's that aggression in public. Monitoring the vital signs is worth its weight in gold to rule out any person who has a severe intellectual disability for anxiety symptoms. So this is one of the things that I've really found very effective. When they disrobe, flee. This is often another sign of anxiety in public. Disrobing will get you what in Walmart? Anybody want to guess? What does it get you? If you're in Walmart and you take off most of your clothing, no, you don't get arrested. If you're intellectually disabled, you get a free pass from jail. You never have to go to jail if you have severe intellectual disabilities. Anybody want to guess what else happens? They take you back home. See, works like a charm. You all ought to try this. I mean, we should learn from people with disabilities. If you ever go, like if your spouse is taking you to your in-laws and you don't want to go, and when you you pull up the driveway, just fling your shirt off. And if that doesn't work, bite your hand. And then try taking your britches off too. And by golly, you probably will not have to go back to your in-laws again. Cool? All right. OCD If you look at the diagnostic criteria for autism, part of it looks like obsessive compulsive disorder. We really don't know how to pull those two apart yet. I don't know if we ever will. All of my patients with autism that require medication are treated for variants of OCD, and we monitor it. In patients with autism, particularly severe forms of autism, I've seen the most bizarre, intense forms of OCD. One of the cases was a guy that got sent to Lakeshore after he had punched a window and severed his brachial artery. Yeah, there happened to be a nurse about 15 feet away. He punched his arm through a window, severed his brachial artery. She stood on his arm while the ambulance got there. I mean, he was going to bleed out in 2 minutes. Luckily, he survived it. They put him in Lakeshore, and they wanted to know what was wrong with him. So I went back to his day program. He had about an 800-step OCD process that he went through every day. He had certain boxes in certain buildings that he had to kick, that he had to tap with his foot, and then he could go on. My favorite part of his ritual is he had to call the secretary at the building every day, 7 days a week. I don't know what you all would think about this, but having a human being calling you every day, she absolutely hated this kid. She just, and he would call her, she would, "What do you want, Luther?" And he'd just hang up, and that was it. But he had to do it every day. It was unbelievable, the most obsessive, ritualized set of behaviors I'd ever seen. And once we treated him for OCD, he quit all the aggression because he would not complete his ritual. Staff would take him to the workshop. He would punch somebody. They would take him back to the house, and then he'd get going on rearranging his little thimbles. He was into thimbles. Anybody here collect thimbles? Apparently, there's a whole world of thimbles out there. Metal ones, pewter, ceramic. How did he ever, I don't want to get thimbles? Panic disorder, again, looking for that elopement, disrobement, the yelling, the screaming, those very discrete onsets. So think about what affects the general population. It's most likely what's affecting people with disabilities. There's not going to be that much difference. You just have to modify the criteria. People with severe intellectual disabilities are lightning rods for physical trauma. I've been down this road 100 times to treat a patient who has a lot of aggression, a lot of trauma. They're very destructive. You kind of get them on medication, PTSD, they calm down, and then the parent will come back and say, you know, I was the one that did that to him. A sibling. He used to hit my mom, and the only thing that ever made him leave my mom alone is if I beat him real good. I've got a small collection of patients in EDC that have been kept in shacks or small buildings connected to homes when they have their like manic episodes, and they would just stick them in these little shacks and leave them there for 6-8 weeks until the mania kind of resolved. And then they would come out of it not only with the bipolar disorder, but now with the severe trauma. Acute anxiety symptoms, particularly in patients with severe intellectual disabilities, is undifferentiated from psychosis. They look psychotic, but the treatment is going to be very different, so you want to try to kind of make sense of that. But self-injurious behavior is a big part of this. Now that the kids are in jail, maybe we can take that vacation that we always wanted. So you find these people in all kinds of forensic settings with severe aggression, all kinds of sexual trauma, and then enact the sexual trauma on a kid at Shoney's bathroom. And so thinking of PTSD can be very, very helpful. Depression is very prominent in the field of intellectual disabilities, particularly those with severe and profound intellectual disabilities, because they're institutionalized. And I don't know if any of you all have ever been to a developmental center or a psychiatric institution for people with developmental disabilities, but a gray cloud hovers over the facility, and when you walk in there, you get depressed. If you work there, it's overwhelming, and it's very depressing. And this is a big part of helping these people transition out into the community. Needing to have waffles for breakfast, just little simple things that make a huge difference. The staff will often prefer individuals that are depressed because they are completely shut down. I had one individual, I was seeing the other guy that was in the house for aggression, and there was this guy's name, Billy, and Billy just sat there. And I asked staff, does he ever laugh? No, Billy's fine, don't you? They called me Dr. Dink. Don't you dink him. Don't you mess with him. I said, Billy's depressed. He had all these terrible bowel problems, was not sleeping well, nothing ever made him happy. And so we put him on Prozac, 40 milligrams of Prozac. He starts talking. He starts working at his job. He earns money. And he had a vision for the future. And no one will ever guess what Billy's vision for the future was, which was a hot air balloon ride. Now, there's a problem with that being your vision for the future, is that if you get on a hot air balloon, staff has to go with you. And the staff member was this girl from Greene County who had an attitude. I don't know if you all know who I'm talking about, but I mean like a really bad Southern girl attitude. She's like, I ain't getting in the basket and dying. And Billy's like, we're going to ride the balloon. Yay. So she gets in the basket and completely makes a scene. And the guy who's doing the hot air balloon gets angry at her and drags the bottom of the basket on top of the trees in the field while they're taking off. And she told me, she says, I was in that thing screaming, I'm going to kill you, Dr. Dink. I'm going to kill you. Yeah. Now, if you go to a NASCAR race, you will find the NASCAR drivers spending time with people with disabilities before the races. So they get these visions for the future that the staff love and some of them that the staff hate. And it's treating them for their depression. The gastrointestinal stuff is huge in the field of depression. I don't know if any of you all have ever struggled with depression, but the stomach issues seem to be kind of connected to it. And I see this a lot in the field of developmental disability. So one of the things that we'll monitor or track is bowel movements because they all have bowel data. They have terrible bouts of constipation. The anxiety stuff looks like irritable bowel syndrome. So you can really learn a lot by paying attention to somebody's bowel habits when it comes to people with disabilities. So kind of keep it in mind. The other thing is that patients who get manic and have severe disabilities almost always get severe crippling depressive disorders. And so you're running this balancing act of treating both. And they're very, psychotic symptoms are very prominent. My clinical experience has been, I don't see a lot of psychosis in the general population when they get depressed, but I do in the field of disability. And the literature supports that, and we're really not sure what the deal is. So this is the diagnostic criteria for depressive disorders, and you can see, you can monitor this fairly easily. How much of their meals do they eat? Let's look at their sleep data. How would you measure concentration in a person with severe intellectual disabilities? Anybody want to guess? Their ability to concentrate or focus. What I do is I look at their paycheck, at their little jobs. So they're like putting springs in the bolts that go underneath car seats. How many can they do? And we just take a look at that. Favorite activities are fairly easy to track. So do you see how you have to kind of modify things? All right, so let's keep going. Mania, we've talked about this with the case of the individual that was the excessive mastication. This is where I tend to see a lot of physical injury in people with severe disabilities. They're just agitated, they're restless, they're provocative, on and on it goes. Psychotic disorders are often the most common diagnosis that's incorrect in the field of disability. And this is usually because the clinicians feel crazy around people with disabilities. They're overwhelming, they're mind-boggling, they have these severe medical problems. Seizure disorders and psychosis go hand in hand. So if I get a case with a patient who has a seizure disorder, intellectual disability that no one can kind of make sense of, I just assume it's psychosis. These odd, unusual delusional disorders. I had a gentleman who had a seizure disorder, and he was convinced that he was a NASCAR driver. And staff would bring their cars to work, and then he was convinced that those were his cars. And then staff would go to get in his car, and you all can imagine how this went. So he got into multiple physical altercations staff when it came time for them to leave. And then he came up with a better idea, which is to put sand in the gas tank so then they couldn't take his car home. How would he know this? Does anybody have any idea? Is it just instinctual that we know that sand should not go in a gas tank? Because by golly, it worked. People did not take their cars home. All right. The other thing I would recommend that you do is if you get a patient who has developmental disability, say with Soto syndrome, just Google it, because there's distinctive types of psychotic disorders that go with certain genetic syndromes, Prader-Willi, Huntington's chorea, other movement disorders or any kind of developmental disabilities that affect the movement centers of the brain. Watch out for psychosis. The other thing that I see in this population is catatonia. I haven't seen a catatonic individual in the general population in years. I see a catatonic individual with severe intellectual disabilities every year, one or two. And these are classic cases of catatonia. It's usually untreated bipolar disorder, so keep it in mind. So let's take here's a little psychotic joke for anybody who remembers Connie Chung, co-anchor. Does anybody feel a little like this is funny? Well, you're a little schizophrenic if you think it's funny. It's just a little schizophrenic. Enough to. Personality disorders, I won't say much about those. We don't use this label much in people with intellectual disabilities. We had an argument, and now he's trying to make me feel bad. This is a good psychiatry joke, isn't it? See, you all will laugh at a hanging joke. See, that's all right. So again, here's your differential diagnosis. Always start with medical problems, then look at the medications, and then think about anxiety, depression. And you're just kind of walking through the catchment area studies. And you have to be very rational, thoughtful, and kind of block out all the aggression and the bizarre behavior. You want to kind of fall back on these very rational, thoughtful treatment algorithms. Make sense? Otherwise, you'll be completely overwhelmed. You'll just never have a chance. All right, so let's take a look at behavioral data, and then I'll try to finish up. So what we do, the DSM-ID, or the DMID, this is a published book by the National Association for the Dually Diagnosed, and we basically went through each of the diagnostic categories and modified them for people with intellectual disabilities. I don't think that it's a particularly helpful document when it comes to each patient, but if you happen to take on a patient, change the criteria based on the behaviors that you're seeing. And then you want to monitor those behaviors. The staff has to write them down. And you want to look at, kind of maybe duration, frequency, or intensity. Self-injurious behavior, property destruction. Again, those are the things. The other thing that I always like to add is monitor improvement based on positive behavior. So like with Billy, what we did is we used spontaneous verbal exchange. Billy never talked to anybody, but when we put him on Prozac, he would go up to people and say things to them. And that was a sign of improvement. And it was a substantial improvement for him. We had a family member of Billy's who came to visit him who did not know he could speak. And Billy will carry on a conversation with you now, especially about the hot air balloon ride. He was very upset when those people were killed in the hot air balloon. A staff member had the nerve to, y'all remember that, when it caught on fire and there was, trying to scare Billy out of it. All right, so here you can see what we've done is we've taken the diagnostic criteria for OCD, and then there's the behavioral equivalents, and then the staff just records them. Make sense? And this is something I just made. I just made it up. Completely created this on my own, and I'll get a consult. Somebody over the internet will want me to help them with a case with developmental disabilities, and this is the first thing I send them. What are the problematic behaviors? What do you think the diagnosis is? We'll modify the criteria, and then I'll ask them to track the data. And I think unless I do this, I'm lost. I don't have a chance. So we use a whole bunch of different types of data. Time samples by staff are probably the easiest thing to do. So if I have somebody with OCD, I'll get staff to sit down with them for 10 minutes and watch them, just with a little counter, and count how many times he adjusts his clothes, right? Or somebody who has mania and we're concerned that How many times did they yell and scream during that hour? And it's some of the best ways to monitor it. And then patient-generated data, you would not believe what people with intellectual disabilities can write down, especially if they have a calendar. And they'll write down the sad face or face, they'll tell you their mood, how many times they've had hallucinations, how many times they've hit people. It's amazing how much data they can generate themselves. And you just tell them, every time you hit somebody, you write it down on the calendar on the refrigerator. You're like, okay. And they do it. And they're very honest often. The staff data is usually consistently inconsistent. So I've actually gone into a home with a patient who was depressed. There was a lot of use of sleep data to monitor the depressive symptoms, and I found the sleep data, and it had been filled out for the remainder of the year. They just went ahead and filled out the sleep data for the rest of the year, which I thought was really cute. At least they were getting their job done, and it was proactive. Probably highly inaccurate. Okay, so here you can see. This is what we base our medications on. Does that make sense? So there's the OCD. The repeating is the time sample over here. Here's the time sample. Screaming episodes, that just comes from the behavioral data. And what you're seeing here is putting it on a graph. And you see these two lines right here? Anybody want to guess what happened during those two lines? That was the introduction of a medication and then the dose increase. Did it help? What do y'all think? Maybe? Look at what happened to the aggressive episodes. They completely resolved. You see? So then when people come to me and say, well, the medications aren't helping, I'll say, well, show me the data. So I'm giving that person a voice. Otherwise, we're just guessing. So this is the way you tell medications are effective. Otherwise, what are you dependent on? Staff who brought him in. And they'll tell you how he did on the drive over. So when you have that longitudinal data, you can begin to get the sense as to how things are effective and what's working. And the way that we tend to run our clinics is if I don't have any behavioral data, then people don't get medications. There's just no otherwise I'm just guessing. I'm completely dependent on this staff member who comes in and says, yeah, he's all right. You know, they don't know. They have no idea. They're just talking about the drive over. The other thing that we need, because there's so much involvement with the Department of Justice and TennCare, is we have to establish lowest effective doses, particularly of these medications that require blood work. And this is the way we do it, is we just decrease the dose, monitor the behavioral data. If the data goes up, then we go back up on the dose. If the data doesn't go up, then we keep going down on the dose of the medication. And it's all data-driven. So here you can see where we made a medication change, and you can see what it did to the data, how it had that upward trend. So we'd established our lowest most effective dose. So the technology of behavioral data is kind of the pillar of treating patients who are averbal. And without behavioral data, you'll have very poor outcomes. You just don't know what you're doing. So when you're looking at these patients, think medical, medical, medical. Take a very close look at all the medications that they're on. Get that behavioral data established and base medication changes on the presence of data. That's what should drive all of this. Otherwise, you're completely at a loss. So when we decrease this person's medicine right here, and we saw the spike in data, and then we put the dose back, had we found our lowest, most effective dose? I mean, it's obvious, isn't it? And when the pharmacist from TennCare comes back and says individuals on an atypical antipsychotic requires a dose change, and I said, we just found our lowest, most effective dose. There's no reason to do this to the individual again. So let me finish up with one last case. This is one of the cases that had to do with the establishment of Green Valley. This is a gentleman that was having severe aggressive episodes at Green Valley. And he's an older gentleman, and the way he would express his frustrations, he would snap and bark and bite his own leg. And he was extremely flexible, so he could just bite the bejesus out of his calf and his tibia and his ankle, and he'd yell and scream. And they asked me to consult on him, and I'm like, I don't know what this is. And they had an actual videotape of him going through this whole bizarre explosion of behavior. And I thought, I have no idea what that is. So I went to his old records and I found something, which was this article from the Knoxville News. You can see it's dated 1952. And what it was is that he was born in a part of Greene County where they had no medical care, and he was born at home. His mother never got any prenatal care, and her husband had tertiary syphilis, and he died in prison of tertiary syphilis. She did not have the kindest words in the world to say about her husband when I contacted her, and she was in her 80s at this point. And she didn't know what to do with this kid. She had this kid, and he had intellectual disabilities. She had 3 other older children. There was quite a gap, about 7 or 8 years. And she had this kid. When he was 2 years old, he would fight with her. By the time he was 3, she said he could beat her up. He was so aggressive, so violent, so agitated. So she kept him on the front porch in a cage. And the son had hunting dogs. And the only thing that really seemed to soothe the boy was to put him in the cages with the hunting dogs, and they would play and they would fight. And people in the community heard about the dog boy. And she built a wooden fence out around the house, and she would keep him out there with the dogs. And people would come to the house and visit and look at him. And for $1, she would sell them a piece of meat, and they would throw the piece of meat out in the backyard, and the dog and the boy would fight for it. So this guy at the Knoxville News Press heard about this and published a story. And it led to the genesis of Green Valley Developmental Center. His case number was 4. So when I saw him and I looked at this behavior, I thought the two should be related. What do you think? I mean, he was raised with wild dogs, hunting dogs, and he's having what looks like, staff said he was acting like a dog. He would growl and carry on. And so the Department of Justice was coming to Green Valley because they had all these people on phenothiazines, and they looked at my report and they told me I should publish it and entitle it Canine PTSD. What do you all think? I could become the world's expert on feral children with canine PTSD. I didn't want to publish it. I didn't think it was a good idea. So whenever he'd get agitated, the medical doctor would give him medications, and the guy he would become comatose. He would just collapse. I never understood that. You give him milligrams of Klonopin, and he would sleep for 8 days. So we didn't know what to do. So we established some behavioral things. I thought maybe part of this was depression. That, he was just dysphoric and unhappy. We tried him on a little duloxetine. I'm not going to tell you the story about Betsy because it's lewd. But anyway, as you can see, he was clearly doing this possibly for attention. He was also possibly doing this for an escape, to kind of get away from things. But this biting, it just didn't make sense. So what we did is we took a look at where it was occurring. And again, as you can see, it tends to occur in the evenings. Anybody want to guess why he's much more prone to these episodes at about 17 to 1500 an hour, at about 5 o'clock? Anybody want to guess why? Mealtime. For who? For the dogs. So, he was brought up in this environment until he was about 14 or 15 years old. And that's when his brother fed the dogs, was in the evenings. And so that trauma was still he associated that time of evening, and he would have these episodes. And I'm telling you, it was violent, and he did severe tissue damage. And they all occurred around the same time. It was very odd. So what we did is we gave him a lot of attention, and he really preferred attention from female staff. So we took all the male staff away, and we gave him female staff. The other thing is that we taught him a way to let people know that he wanted attention. So if he clapped his hands, people would come over to him. And I think what was happening is he was kind of freaking out. he would start to get anxious and nervous, and then, and if he could clap his hands and the female staff could come over to him, it would soothe him. It would just kind of calm him down enough that he wouldn't have these full-blown kind of, I don't know, would it be a panic attack? I've never really understood what it was. And then we taught him to put his hands in his pockets or to sit on his hands when he got really nervous. And then when we did that, he would just sit there and he would shake, and he would look absolutely freaked out. And it would last for 15 or 20 minutes, but he wouldn't bite himself, and there's the behavioral data. So you can see the blue line is the aggression, and you can see how destructive he was when he was in that kind of PTSD state. And then the property destruction was usually him throwing things, breaking things, yelling and screaming, and then the self-injurious behavior was all the biting stuff. And you can see the improvements that. And we really, all we did was give him a low dose of an antidepressant and tried to kind of look at this as a distinctive psychiatric syndrome. Prior to that, people just said, well, that's Ricker. That's what he does. He'll bite you. He'll sling poo. All that disappeared. You know, so when you see patients with intellectual disabilities, think about modifying those diagnostic criteria and how do you manipulate them to make sense of their behavior. And all of those problematic behaviors are just a way for them to voice their distress. Think about medical, think about medical, think about medical, look at the medications they're on, and then kind of go through the treatment algorithm. Think about anxiety disorders, think about mood, maybe psychosis. So I've got a few minutes left if anybody wants to ask a question. Well, thanks so much for coming and your interest in people with severe intellectual disabilities.